So we'll move on to the next speaker. This is Dr. ADITYA Sethi. He'll be speaking on pediatric cataract. Sethi. Sorry.
Misprinted.
Pre and intraoperative pediatric cataract. Over to you. You have 5 minutes.
Thank you so much. First, I'll start by thanking AIOS for bringing all of us under one roof after so many years and giving me an opportunity to present in front of my seniors, teachers, colleagues, and friends. I'm going to be talking about pediatric cataract, the pre and the intra part. So I have no financial disclosure here. So this is what I ask myself when a pediatric cataract comes to me. Can I have my presentation? Yeah. So first question I ask is the cataract visually significant? Can vision be improved with surgery? Second question I ask is when to operate, when to put an IOL, what formula to use, what is my target post-op refraction, and how different is this procedure going to be from an adult cataract? The other two questions will be taken in the next talk. So what is a visually significant cataract? I think this is very important for all of us to know that visually significant cataract is in the central visual axis, is bigger than 3 mm. Posterior cataracts, no clear zone in between. Retinal details not visible with direct ophthalmoscope. Nystagmus or strabismus present and a poor central fixation. And often this is misunderstood that amblyopia needs surgery, which I think is not always the case. These are a few of the different types of cataracts we see. So ask yourself this question: can vision be improved with surgery? Check with a direct or an IO for red reflex in the size of the cataract. If one can view well with a direct or IO, you can reconsider doing surgery immediately. Objectives of the surgery should be to clear the central optical zone, remove scaffold for PCO formation, maintain support for IOL, should be least traumatic for the child's eye, and minimum complications should be assured. Maintain the rim and document in case you're doing a planned aphakia. So what is the timing of surgery? Remember, if it's visually significant, earliest is the best, and in unilateral, earlier than earliest as compared to the bilateral. High risk of glaucomas in very young children has been documented, and consider corneal diameter, the size of the eye when you're doing examination under anesthesia. Also consider GA risks. There are higher chances of post-op apnea in 1 to 2 months age group. So we have the unilateral study, the IATS, which has given us very good guidelines, and the bilateral cataract study, which has come from India itself, which has compared the onset of cataract, the timing of cataract, and whether the IOL should be implanted. So when do you put an IOL? The general consensus now is IOL for most children. Unilateral cataracts, IATS also talks about leaving them aphakic. The benefits was weighed only for unilateral cataracts. The bilateral cataract study by Dr. Vasavra also considered the age, diameter, and the axial length whenever you're deciding what IO formula to use. A lot of papers are there, and SRK2 has been the least variable and often used. I also prefer to use the Barrett's calculation because it's much easier nowadays. The thumb rule, when you're talking about myopic progression, that I use is the rule of 7, where I use the age and the target hyperopia, and the total should be 7. This is usually for 7 years of age or less. So how pediatric cataracts differ from adult? It's a unique challenge. Anterior chamber can be unstable, increased capsular elasticity can be there can be decreased scleral rigidity, higher tendency for PCO formation, and nucleus is soft and easy to aspirate as compared. The first thing I want you to know is about your GA. So remember to know what sort of GA will suit you. If you're a beginner, maybe intubation would be a better option than iGel or a LMA. Also, a little bit of muscle relaxant should be given. Use a head ring and shoulder support because remember, you can't manipulate the head during surgery. So handling of the anterior capsule, when you're talking about the anterior capsule, the dilatation is quite good with 1 lakh adrenaline. Stain with trypan blue. Elasticity is different. Always inflate the anterior chamber very well. Overfill it for better control. And use high density viscoelastics if required. Grasp, re-grasp, and then complete your X's by pulling it towards the center. Alternative method, Dr. Nischal has shown in younger children his push and pull method. You can also use a Victorexis technique, where you can put a cut rate of 150 to 300. I prefer to do this only when I'm doing a lensectomy, planned aphakia. So lens aspiration, remember to do a multi-quadrant hydrodissection. The advantage is the reduction in operative time. What I would want you to also take home is always strip the cortex from periphery to the center first, rather than eating the nucleus, because in cases of traumatic cataract, when there can be a PC opening, it may lead to complications if you don't practice this regularly. PCC for all cases under the 7 years. I even do it for older children because it's very difficult to get them under the YAG laser later. So underfill the bag, let the PC come up a little bit, take vertical nick, and then use your excess forceps. Then you can push a bit of viscoelastic in the Burgess space so that you have better control and you can make the posterior capsular excess complete. Anterior vitrectomy, the idea is to clear the visual opacity. There should be no visual opacity later. So go ahead with your vitrector, put your port down, go into the PC opening. The end point should be when the PC margins curl and fall back and the round shape of the posterior capsular excess is maintained. You can use tricort or you can use your the spatula to make sure that there's no vitreous in the AC and the PC is round. You also have the vitrectomy approach with a vitrector. IOL insertion and choices, always prefer in the bag because this is a long-term output you're looking for. So single piece IOL in the bag or a 3-piece in the bag or in the sulcus is a good option. Always keep a backup IOL because pediatric cataract, you never know what happens and you have to assure that general anesthesia is given only once. Can consider the latest locking in or the IOL technique. Remember, it's like a plane landing. So when you're injecting the IOL, make sure it's leading haptic down into the bag, and once you're reaching the bag, just pull up. Closure, always take a suture. 10-0 vicral wound sutures have to be taken. And now, in conclusion, proper evaluation, medical surgery, correct follow-up, and amblyopia therapy will lead to good results for your children. Thank you.